All right, good afternoon, everybody. I want to welcome you to our second Berkshire Healthcare Forum. Today, we have a really exciting lineup that will focus both pathology and plastic surgery. So let me just give a warm welcome to some folks first. Today, you're going to hear from two of our pathologists, Dr. Alida Hayner-Buchan, and she's going to introduce you to Western Mass Pathology, which has been with us for several years. She's one of our group's physicians. Actually, she's the interim lead right now while Dr. Krochmal is out. Western Mass Pathology is an independent provider service group that has worked cooperatively with BHS for more than 50 years. It specializes in anatomic and clinical pathology and is closely integrated with the BMC lab. Dr. Alida was born and raised in Troy and attended Albany Medical College, earning her degree while raising 3 kids under the age of 5. Imagine that. It's really impressive. Dr. Buchan completed her residency and fellowship at Albany Medical Center, and she joined Western Mass Pathology in 2012. We also have Dr. Jones from the pathology department, who was born and raised in Troy, New York. So there's a common theme there. He earned his undergraduate degree in chemistry from RPI and then attended Albany Medical College, where he received dermatopathology training under J. Andrew Carlson. Dr. Jones completed an Oncologic Surgical Pathology Fellowship at MD Anderson Cancer Center and began providing services at BHS in 2021. So welcome, Dr. Jones, as well. And then when pathology is done, we have Dr. Long here, Dr. Zachary Long, from our plastic surgery department. Dr. Long grew up in North Carolina and went to medical school in West Virginia. He completed his fellowship in plastic and reconstructive surgery at St. Barnabas Hospital in the Bronx, where he met his wife, our very own Dr. Victoria Tuttle. And while I was up here visiting Dr. Tuttle while he was in his fellowship, they decided they liked the Berkshires and Dr. Tuttle, who joined us in 2018. We then found Dr. Long, who joined us 2 years later in 2020 after he completed his fellowship. So we're thrilled to have them both. Dr. Long provides a wide variety of general plastic surgeries and hand surgeries. So again, welcome, Dr. Long. I think the next thing we want to do is just go over some of the housekeeping that we have. Let's see. Show how to use the mouse. Yeah, we'll get it over here. Okay. So those are the introductions of our leaders. So again, we're going to spend a few minutes on the lab in general, and then about some of the pathology services that we provide, and then plastic surgery. And at the end, we'll have questions and answers as well. So let's all remember that this forum is for our entire BHS community, both employed and private practice providers, as well as the administrative and support staff, anyone that has an interest in understanding what we provide here at the health system. We plan on providing this forum 3 to 4 times a year, doing one at lunch and one after work. So we did our first one for these topics last week, and today is our second session at lunchtime. And we're really trying, as part of our strategic plan overall, just understanding what we have to offer to our community, to make connections and share information so that we can better serve our patients and our community. And for all of us that are listening to this webinar, be advocates for our community about the services that are available here. So we are the best promoters, those of us that work here and are involved in the healthcare delivery system. So while we're doing this session, if you have any questions, please post them in the Q&A. If you could include your name of the presenter that you want to ask the question to, that would be terrific. I won't be able to always tell who your question is directed towards. And we will, again, take all questions at the end of the session. And we will also share all the slides at the end of the session with you so that you don't have to take a lot of notes. You can just enjoy the presentation. And so with that, I'd like to turn this over to Dr. Hayner-Buchan to talk about Western Mass Pathology. Thank you.
Hello. So 70% of medical decisions are based on laboratory results. And with that in mind, our entire laboratory team is committed and engaged with patient safety, professional competency, and quality assurance. The laboratory has 4 sites and 12 collection stations throughout Berkshire County. We provide expertise, programs, and technology that is more often found at an academic center. For example, we have a blood donor program and Bloodmobile, which provides enough product to keep our own patients through their surgeries and any other procedures they need. So since January, we've collected over 1,200 blood units and almost 80 single platelet donor units. This is really important as right now the Red Cross has quite a shortage, and many hospitals throughout the Northeast have had to cancel surgeries as there is not enough blood products, and we have our own supply, which is pretty spectacular. We also provide molecular testing, flow cytometry, mass spectrophotometry, and toxicology. We have a School of Medical Technology, which is also very important as the number of these schools has steadily decreased throughout the country, and there is a projected shortfall of almost 100,000 medical technicians and technologists by the year 2025. Our laboratory has processed almost 2 million tests in 2019 and almost 50,000 surgical and cytology specimens. We employ 187 people across all sites. Oops. So many people think of pathologists as sitting in their office behind a microscope, but you can find us throughout the hospital. We go up to interventional radiology and endoscopy, where we help the clinicians know if they have enough tissue to make a diagnosis and for any ancillary studies needed. We perform frozen section diagnosis. This is intraoperative consultation where we may tell the surgeon that the lesion they're excising is benign or malignant, and if they have it all or they need additional tissue to make sure they have a clear margin. We perform gross dissections, and this is important as sometimes there may be more than one lesion in a specimen, and if the lesion is not sampled, the correct diagnosis is not made. It also is important for accurate staging. We diagnose biopsies such as lymph node biopsies, bone marrow, or gastric, breast, and also simple and complex surgical specimens and cytology specimens. We perform autopsy, hopefully to answer a question from the clinical team or a family member. However, in this day and age, with extensive state-of-the-art imaging and testing, any unanswered question may not be answered by us at autopsy. We teach residents, medical students, and medical tech students. We're integral members of the interdepartmental conferences and tumor boards, including for lung cancer, breast cancer, prostate, and GI malignancies, as well as leukemia and lymphoma. We also perform clinical pathology consultations. We are members of many BHS committees, including the Cancer Committee and Breast Cancer Leadership, Transfusion and Trauma Committees, and the others listed here. Our focus is on test quality and patient safety, and we are accredited by the College of American Pathologists, and each of our lab sections participates in proficiency testing, where the CAP sends us specimens and we provide results, and those results are compared to the other CAP accredited programs throughout the country to ensure that the results are reproducible and acceptable. We assist providers with understanding laboratory results when requested, and we're stewards for the hospital, trying to recommend cost-effective testing when applicable. We refine our test menus in the hospital by evaluating and implementing new technologies, and we analyze our internal data and benchmarks to make sure the test ordering practices are appropriate. We communicate new testing information and collaborate with interdisciplinary teams to provide high quality care. And this is evidenced by the 6 platforms we brought in for COVID testing. Pathologists like to have as much tissue as we could get, but in this day and age, this is more likely what many of our specimens look like with these. This is a tiny lung biopsy from which we make a diagnosis, and we often need immunohistochemical stains. So if a tumor is poorly differentiated, a lung tumor, if it's P63 positive, we'd know it's squamous cell, or TTF1 positive adenocarcinoma. If those are negative, we may need to do additional stains like a GATA3, which would indicate metastatic breast or urinary tract carcinoma. We may also perform prognostic and predictive testing, such as PD-L1 testing, so that a patient may receive Keytruda. Our laboratory results, both pathology and clinical, are available immediately upon test completion in the patient portal. New technology we've brought in within the last 6 months includes this Sysmex hematology analyzer with Cellavision, which has improved turnaround time from 6 minutes to 3.5 minutes. It provides image storage and can be used as a teaching tool, such as here we have a neutrophil with anaplasmosis. A new urinalysis analyzer, which also provides automated and digital workflow. It has decreased the turnaround time from 25 minutes in the past to about 15 minutes. And instead of taking the slide to the microscope, the nephrologist can look at the urine image. And in this image, we have a granular cast and a triple phosphate crystal. Again, the images can be saved and used to teach. In the future, the next 6 months, we're bringing in VoiceBrook for pathology, which is the voice recognition system that will help improve turnaround time, standardize our reports, and decrease potential errors. The MALDI-TOF is a rapid and accurate identification of microorganisms using mass spectrophotometry. And in molecular biology, we're bringing in the Tomcat, which decreases repetitive motions and improves workflow. This is some of our wonderful lab team at BMC. And these are our pathologists. We're all boarded in anatomic and clinical pathology. And in addition, Dr. Homan is boarded in hematopathology and has expertise in transfusion medicine. Dr. Kirby is boarded in cytopathology. Dr. Lee is boarded in cytopathology and has expertise in GI pathology and medical liver biopsy interpretation. Dr. Krochmal is boarded in cytopathology. I am boarded in hematopathology and have expertise in genitourinary pathology. And our newest pathologist, Dr. Jones, is boarded in dermatopathology and has expertise in neuropathology, bone and soft tissue, and GI pathology. And with that, we have Dr. Jones. Oh. And if you need a clinical pathology consultation, you can reach us at this number and ask for the pathologist to answer your question.
Great. Thank you very much, Alida. I've known Alida for 25 years. We went to medical school together, residency together. And after I came back from MD Anderson, she had done a heme path fellowship at Albany Med, and we worked together for over a decade. So when a job became available here at the medical center, and she let me know that I could apply for it, I gladly did that. And over the last 2 months, I realized that I've landed at an absolutely fantastic spot for the second half of my career, and I honestly couldn't be happier. Susie Holman, who you also saw in one of the previous overheads, is a close friend. I've known Susie for over 2 decades and have fit in, I think, very well with the group that's here. You know, just so that you know, I've been at several places. Albany Med was my main spot, but we would cross-cover a number of community hospitals. Diagnostically, the team that is assembled here is second to none. I mean, it's absolutely fantastic. A broad range of expertise and the ability for me to show cases around and get a really top-notch consultation from people 2 doors away. So again, couldn't be happier, and looking forward to the next 2 decades. So what can I do maybe to impact the group and the community at BMC and the healthcare system? I come with a general background, so I've done breast and head and neck and lung, et cetera, like the rest of the members of the group. But I've spent the particular time and interest in several areas of pathology that generally tend not to be a spot that most general pathologists like to spend time on, and they tend to be the kind of cases that go out for outside consultation. So first and foremost, I hope to kind of stop that lab leakage and keep cases in-house, be able to diagnose and manage patients right here in Western Massachusetts. These are the areas that I spent time on, and I'd like to at least give you a little bit of background in it. So a few summary statements about how I feel about landing here and how I hope to develop relationships that are deep and meaningful in terms of clinical pathologic consultation with my colleagues in the community and become a part of the Berkshire system. The biggest impact I think I can make is in skin disease. So I did a fellowship in dermatopathology, as mentioned, under J. Andrew Carlson at Albany Medical Center. He and I worked together for 20 years, and we split a service that had 25,000 accessions. The 25,000 accessions included not only diseases of the skin, but also oral mucosa, dental pathology, genitourinary pathology to include vulvar biopsies, and anal and perianal disease. So I think I bring to the table somebody who has seen slides of inflammatory and neoplastic diseases that cross-cover several subspecialties, primarily with dermatologists and plastic surgeons, and we'd like to be able to grow the amount of work that comes into the institution by partnering with local dermatologists. Dave Alpern has become a good friend over the last few months, and he's using our laboratory, and we've had a really great opportunity to develop a collegial relationship via face-to-face conversations and telephone conversations about individual patients suffering from inflammatory and neoplastic diseases that really require not only the histologic evaluation, but also the entire clinical picture to make the appropriate diagnosis and therefore guide therapy. In the same vein, I've developed a very nice relationship with Dr. Long, who you'll hear from in a few moments. We've done frozen sections together and talked about both inflammatory and neoplastic diseases and how to care for the patients of the community. In my past experience, I did do a monthly grand rounds, and as we grow the service and develop connections with local dermatologists, we hope to do the same. But suffice to say, the GYN community, I'm comfortable with vulvar biopsies, and the GI community, I'm very comfortable with anal and perianal disease, and will provide consultation in that setting. So another area that I spent a lot of time on over the last 20 years is gastrointestinal pathology. Why is it important? It's probably about a quarter of all accessions in almost all laboratories, to include our lab here. And Dr. Lee, who has been here for a decade, is absolutely fantastic. Has an interest in GI and an expertise in GI, and is currently really the in-house consultant that folks will call and ask for a second opinion on liver biopsies and GI tubal biopsies. I hope to partner with her to kind of offlay some of that work that she has to do. Things like general GI biopsies everybody is comfortable with, but there's controversial areas, things like dysplasia and Barrett's. Is it present? Is it not present? Is it low grade? Is it high grade? And these carry clinical implications. So again, to be able to have another set of eyes that's comfortable in that region to share cases back and forth and to attempt to diagnose and manage patients right here in Western Mass and not have the need for send out. In addition, medical liver, inflammatory disease of the liver, autoimmune hepatitis, biliary diseases, drug-induced liver disease. They can be difficult and complicated for somebody with a general background so have the ability to share cases back and forth with Dr. Lee, put it into a clinical pathologic radiologic context, I think will be very helpful. And again, stop any lab leakage that we've experienced. We currently have a GI tumor board here. I ran it at Albany Med, and we'll be glad to play an integral part in it as time goes on. bone and soft tissue, you know, probably right off the bat, you say, hey, we're not going to run a sarcoma service here, and I understand that. But over the last 2 months, I've realized how fantastic the interventional radiology team is, and how easily they can gain access to mass lesions in the retroperitoneum and other sites. So most of the time, we're making this diagnosis because a core goes into a soft tissue mass, and we want to be able to triage it appropriately, determine whether it is a true sarcoma, a pseudosarcoma, or something totally unrelated to the sarcoma family, like hematolymphoid malignancy or a metastatic disease process. So with the last 2 decades, I ran the bone and soft tissue sarcoma tumor board at Albany Medical Center with the orthopedic oncologist, and I'm very comfortable in that realm. So I hope to add some expertise there. A lot of times when we make this diagnosis, it is a completely unexpected finding. Somebody goes to their primary, has a lump or bump on their skin, gets it excised, they're biopsied, and lo and behold, it ends up being a sarcoma and not what was expected, a cyst, a lipoma, et cetera. So to be able to appropriately triage those cases and not have to send them out, I think will add some value to the team. For the last 25 years, I ran the Neuropath service from probably day one of my residency in Albany with Dr. John Chen. We did 350 brain and spinal cord biopsies a year. And over the last 15 years, after I was an attending, we split that service 50-50. So as I said last time, I'm getting used to wearing a tie and a suit coat. I'm much more used to being in scrubs for 26 weeks a year and in the operating room doing an intraoperative touch prep and frozen section on both primary and metastatic disease to the central nervous system. Joe Emmerich was at Albany Med when I was a resident and a junior attending, so we developed a great relationship at that point, and I'm really happy to be able to continue that here at BMC. We've already had several cases together, and they're the kind of cases, when you're talking about primary CNS neoplasms, they're the kind of cases that, again, would generally be sent out to a larger quaternary, tertiary medical center. And I think with my background, we can keep it here, we can make the diagnosis, we can order the appropriate molecular testing so that the patient is provided with the care that they need and the treatment options that are available to them. The last thing, which I think I skipped over quickly, is education. I'll be honest, I totally understand that I had to give up that part of my career in order to come to a community hospital. But as I walk down the hallway, I realized that there's posters everywhere that you have a vibrant residency program. And so I'm just offering myself out to the residents and the attendings that are interested in an academic component. I would be really happy to be involved with poster sessions, platform sessions, provide the histologic sections that you need with descriptions. That kind of stuff is fun for me. And in addition, anybody that wants to come down, look at slides one-on-one across a multi-headed microscope. Again, something that I would embrace and really be glad to do so that we can manage the patients appropriately. And with that being said, I will now defer to my colleague, Dr. Zachary Long, to get an idea of some of the expertise he can provide to the community. Thank you very much.
All right, thank you very much, Dr. Jones. Hi, everybody. I'm Zachary Long, plastic surgeon here at BMC. So first, I just wanted to go through some of the services that I provide here at BMC, and then touch on a couple of my more common procedures and some other technology that we use here. So as far as introduction of some of the procedures I do, craniofacial reconstruction, which includes traumatic injuries, upper facial fractures like orbital fractures, nasal bone fractures, eyelid, nose, and ear reconstruction, whether it be cancerous, skin cancer, traumatic injuries like a motor vehicle accident or animal bites or assault, breast reconstruction, including breast cancer, congenital breast deformities like Poland syndrome, and also breast reduction surgeries, hand surgery, including hand tumors, hand fractures, tendon or nerve injuries, and carpal tunnel, body contouring. A lot of times with patients that have undergone a massive amount of weight loss, whether it be from diet and exercise or after bariatric surgery, they come to me for what can be done with the excess skin. Skin cancer, which I will talk about as well. Gender confirmation surgery, male to female breast augmentation and female to male breast reduction surgeries, and then finally some cosmetic surgeries as well. I'll also give a little disclaimer that the photographs that I use in this are from Google. They're not my own photographs because of some HIPAA complexities. So here we have some skin cancer reconstruction. Skin cancer is by far my biggest patient population in my practice. And part of that is also because of the kind of lack of dermatologists in the area. Most of the cases that I see can be repaired with a simple primary closure, whether it just be lifting up the skin a little bit to bring it together or just suturing it together. Typically, I do a biopsy in the office, whether it be a shave or a punch biopsy if it's not already done. Sometimes the PCP or the dermatologist that refers the patient to me has already done this with a pathology report, which is helpful. Then I can do the excision in the office if it's a small area with some excess skin nearby, or as an outpatient basis in the OR if it's a little bit more complex or requires a frozen section analysis. Generally, it can be done under local anesthesia only. Some patients, especially for those that have it on their face or have some issues with anxiety, can certainly be done under light sedation, but still be done as an outpatient. So here are 3 examples of some of the reconstruction that can be done, a little bit more complex reconstruction that can be done with skin cancer removal. The first is a picture of a man who had skin cancer removed from the left side of his nose. The defect there is a little too irregular and large to try and close in a straight line without having significant distortion of the shape of his nose and some of the nearby structures. So this is a bilobe flap that's been fashioned by the nearby skin. It's left attached to its blood supply at the base, simply rotated around and then sutured in place. Heals very well. Oftentimes, if it's in the right spot, it can hide into natural wrinkles and creases in the face and avoids distortion of nearby structures. It's good for basically anywhere on the body, but especially on the face up to a certain size, usually less than 2 centimeters. The next one here is a picture of someone who had skin cancer removed on the back of their finger. Like the nose, trying to close it together in a straight line is going to cause either functional impairment with a decreased ability to move their finger, or there's just not going to be enough skin there to close it. So they took a small skin graft. Usually it's taken from the same wrist. That site is closed primarily, and then the skin graft is put onto the defect and sutured in place. Usually requires a bolster dressing for about a week, relies on a healthy wound bed. So if the wound bed is not healthy, does not have periosteum or some sort of vascular supply, then a skin graft usually is not going to work. Skin grafts are also good in areas that can cause some scar tension, whether it be under the eyelid or over joints and surfaces, where you don't want to risk causing contracture that can lead to functional impairment down the road. And another benefit to skin grafting is that a lot of times with skin cancer, you want to make sure that your margins are negative. If you are doing an excision in the OR without a frozen section, you want to take a wide area to be safe, but sometimes your margins are still positive. With a skin graft, you're not rearranging the tissue and distorting the margin. So when you have to go back to remove more of that, then you know exactly where you're going. And then finally, this woman down below had skin cancer removed off of the end of her nose, similar to the first gentleman, but it was slightly larger than would be needed or could allow for a bilobe flap. So she underwent something that's called a paramedian forehead flap. It's based off of an artery that comes right off of the top of the eyebrow and goes upwards towards the hairline. The skin and soft tissue, the skin and fat is elevated on the forehead, rotated around, and then inset into the defect, but left attached to its blood supply. About 2 weeks later, once the donor or the recipient site has established blood flow into that new skin, then you go back, you test to make sure that it has good blood supply, then you disconnect it from the blood supply at the eyebrow, and then do some fine tuning with the skin. It's good for large areas near the nasal tip. And then rarely you may need a muscle flap or some free flaps for skin cancer, but it's usually with significant head and neck cancers. Another common procedure that I provide is breast reconstruction. There's multiple types of breast reconstruction after breast cancer. It can be either immediate or delayed. Immediate being that at the time of the mastectomy, I go in, I put in a tissue expander or move tissue around to recreate the breast mound. It can also be implant-based with a tissue expander and then finally a permanent implant, or with autologous tissue, which is tissue, skin and fat, and usually some muscle that's rearranged from another part of their body, either their abdomen or their back. Immediate reconstruction has the benefit of only having one initial surgery. So instead of initially having the mastectomy, healing from that, and then having the second part of the reconstruction, or the first part of the reconstruction, but a second surgery, you can avoid that with the immediate reconstruction. But downside is not knowing a final pathology that may require either additional procedures or radiation or chemotherapy that can affect the long-term outcome of the reconstruction. With delayed reconstruction, like this woman that's on the bottom on the left, you have the benefit of an easier recovery because the recovery from a mastectomy is a little bit easier than a mastectomy plus initial reconstruction. But the downside is needing an additional procedure. And on top of that, some of the scarring and healing, natural healing that occurs from a mastectomy can cause the reconstruction later to be a little bit more difficult. Typically, the initial surgery starts with a tissue expander placement. It's basically an inflatable saline implant that's placed either under or on top of the muscle. And then about 2 weeks later, we can start the expansion process in the office, where I place a needle through the skin into the port and inflate it little by little over the next course of 6 weeks to 3 months. Once they're expanded completely to whatever size that they are looking for, or they have started radiation therapy, I stop the expansion process, and then we start talking about the second stage. If the patient does require post-op radiation, I do not do expansion after they have started, just because of some of the damage that's caused by the radiation to the skin. Then after 3 months of the initial surgery, or 3 to 6 months after the final radiation treatment, I see them for the second stage of reconstruction, where I either remove the tissue expander and then place a permanent silicone implant, or we talk about autologous tissue transfer, where I move tissue from their abdomen or their back and rotate it into the defect to give them, to recreate the breast mound. Usually at the second stage of the reconstruction, the contralateral side, if they haven't already had a mastectomy on that side as well, can be operated on to provide a symmetry procedure so that the breasts are similar in appearance and size. Another type of breast reconstruction is free flap reconstruction, where tissue is detached from its blood supply and then reconnected in the chest wall to create that breast mound. However, I do not provide that service here. It requires a tertiary center that has expertise in microsurgical techniques. So this patient here on the right, you can see she initially had a mastectomy on the left. This patient either had a TRAM, which is tissue that comes from the abdomen, which I can provide, that's left attached to its muscle and blood supply, or she had a deep flap, which is the skin and fat from the lower part of the abdomen. It's disconnected from its blood supply and then reconnected. And then she also had a symmetry procedure on the right side. The symmetry procedure is also sometimes that brings up a question in consultation about insurance coverage. The symmetry procedure on the right side is covered by insurance for breast cancer patients. And then finally, a new instrument that we brought on here at BMC that I was familiar with in training is this micro-air fat grafting machine. It's very helpful in breast reconstruction and can be used as an adjunct. Basically, fat is suctioned from one area of the body, usually the abdomen, back, or thighs, washed, and then re-injected in a sterile technique under the skin in either the breast, the face, buttock region, or any area of scar tissue. So with patients that have to undergo radiation treatment, the radiation can cause a lot of damage to the skin that lasts for many years afterwards. The stem cells in the fat help reverse some of those radiation changes and can also allow for increased softness and decreased rates of scarring and painful capsular contracture. In addition, it can be used in HIV-related facial wasting and patients that have lipoatrophy, whether it be from HIV itself or the medications that were used. It's done in a similar way and can provide more permanent facial filling rather than fillers, which typically only last for 6 months to 2 years. And then finally, it can also be used in cosmetic procedures. One common and fairly well-known procedure in kind of popular media is the Brazilian butt lift. It's actually a fat grafting procedure where fat is removed from other parts of the body and then used to augment the buttock region, give it a more lifted appearance. Some risks of it are pretty low. There's a slight risk of infection, although it's very low and is done in a sterile technique. There are some rates of fat cysts where fat doesn't survive, collects and creates a little cyst that either needs to be drained or gets reabsorbed. And it does sometimes require multiple rounds because the entirety of the fat that's grafted does not survive. Depending on whether it's a bilateral procedure, you may need to do an additional round to make it a little bit more symmetric. This is our team. This is my LPN, Caitlin, who basically runs my practice. How you can get in touch with us. For urgent appointments, you can certainly give us a call and we'll try and accommodate the patient as soon as possible. Routine referrals can be sent through EMR, fax, or by phone. And then a lot of patients ask, well, after I see you, how long until I get my surgery? Surgeries can be performed within 4 weeks of the office visit. Here's how to reach us through EMR for our faxes, and any other questions, you can certainly reach out through our office phone number. All right, and with that, I will give it back to Darlene for any other last minute questions.
All right, it looks like we have about 3 questions that we're going to want to have Q&A on. All right, so the first question is for pathology, Dr. Hayner-Buchan. We know that the improvements in processing for urinalysis and CBC saves time. How many of each does the lab do per day? If you want, I can tell you. If you want to tell me. Okay, so 400 CBCs and 125 urinalysis per day. Thank you. All right, next question. Again, Dr. Jones, what's the most challenging diagnosis or type of diagnosis you've made and why? That might be a little bit more than enough.
Yeah, that's always a tough question. We end up getting sort of all comers, right? You never know what you're going to get till you put the slot on the microscope. Probably the pseudosarcomas are the things that are the most difficult or the most frustrating. So, many sarcomas fit into a classic diagnostic pattern. Pseudosarcomas are actually completely benign, but show some overlap with sarcomatous conditions. And obviously, making the wrong diagnosis is going to lead to inappropriate treatment. So I'm very comfortable with nodular fasciitis, cranial fasciitis, periosteitis, Nor's lesion on the hand for the orthopedic surgeons out there. Those can be somewhat challenging. And then the epithelioid variants of sarcomas conditions like epithelial hemangioendothelioma can mimic a chondroid neoplasm when in reality it's a vascular neoplasm. So it's those kind of things that that can be a little bit tricky, a little bit dicey if you haven't seen them before. Luckily, the lab has a full complement of immunohistochemical stains to help us delineate out and make the right diagnosis.
One more question for Dr. Long. How long is the breast reconstruction surgery process, and how many surgeries and appointments are usual for this process for delayed reconstruction?
So breast reconstruction is typically a fairly long procedure and process. I always tell patients when they first come in for consultation, you're going to see me many times over the next 3, 6 months, even upwards of years, even after you're done with your chemotherapy or radiation. You haven't seen your breast surgeon in a long time. You're still going to be seeing me, unfortunately, because the initial stage of a tissue expander can be the first 3 months or maybe even 6 months, depending on what other treatments they need. After that, the second stage is another 3 months. The procedure is done. And then I wait about 3 months for the final healing before I move on to a third stage, which if the patient requires a mastectomy that takes the nipple and areolar complex and the patient requests nipple reconstruction, that's kind of the final stage of reconstruction, which is typically 3 months after the second stage. So it's a long process, but usually it's within 1 to 2 years for the final outcome, depending on the patient's needs and what other treatments they need.
All right, that rounds out all the questions that we had today. We had great participation, so I want to thank everybody. We want to hear from you, so if you have any questions or comments, please send them to Kathy and Muso. Her information is here on the screen. And thank you for your attendance today. Have a good day.